few cases I'll show. Um, when do we treat aneurysm? So aneurysm can be treated by doing nothing, as Rahul told that if it is calcified, if it is not bigger than 5 millimeters, then sometimes we can just observe and not treat these aneurysms, or we can treat by simple coiling or balloon-assisted coiling or stent-assisted coiling, sometimes FD or web, sometimes web with a stent and contour. Now, if I'm treating a ruptured aneurysm by coiling, I generally avoid doing simple coiling. I always use a balloon when I'm doing coiling. And loading with antiplatelets is usually on the day of the procedures or on table if we are doing a stent-assisted coiling. Usually 8F short sheet for the femoral access. I do all my cases with femoral approach. We don't do radial. All punctures are taken by sonography guided because we use a closure device to avoid complications. So 8F short sheet, then we use Neuron Max or any long sheet. In that, either 070 or 050 intermediate catheter, depending on whether you are doing balloon-assisted coiling or FD or stent-assisted coiling, and microcatheters of our choice to coil these aneurysms. Now, balloon, again, it can be a single lumen balloon or double lumen balloon. The advantage of double lumen balloon is that you can start the procedure of balloon-assisted coiling, and then you can put a stent through this balloon and convert into a stent-assisted coiling. Also, in double lumen balloon, you can reshape the wire and again take the balloon. But in single lumen balloon, you have to remove the entire system, change the shape of the wire, and then go again. Otherwise, the lumen will get filled with the blood. Stent, it can be a braided stent like Elvis Evo or Babylio, or it can be a laser cut like Neuroform Atlas or Enterprise. Now, laser cut stent has an advantage that you can have a precise deployment of the stent. You exactly know where the stent will end. Whereas in braided stent, you are not very sure where it will end. But the advantage is that it has little flow diverter effect. It is because it's a braided stent, there are wires. Whereas laser cut is just like a tube. And I usually use braided stents for sidewall aneurysms, whereas open cell for bifurcation or Y stent. But either way, it can be used. Now, this was, I'll show a few cases now. He was a 54-year-old male with no comorbidities, and he had an acute right eye vision loss in January, for which he received thrombolysis, because this was the time during the COVID times he presented to us. And we thought that probably he was vaccinated, and after that he developed this stroke. We lysed him, and he had branch retinal occlusion with IV thrombolysis is completely improved. And this was the watershed infarcts that he had. And this was the first scan. So we thought probably it was a COVID-related complication, and he improved with the treatment. Then he presented with acute onset transient slurring of speech and left upper limb and lower limb tingling, which lasted a few minutes. This presentation was after 6 months. And this was his angio this time. We can see that there is a dissecting aneurysm, possibly, into the ICA. Now, you can clearly see that there is a dissecting aneurysm here. And this is one of the risk factors when the artery is like this and it's not has a straight course, probably is hypertensive for long duration, and this makes this patient susceptible for developing dissection. It's one of the risk factors for dissection. So probably it was a TIA because of giant dissecting aneurysm of ICA. So this was the DSA, and you can see that this is probably the dissected segment. So I decided to do FD with coils. Because the aneurysm was big. Usually when the aneurysm is bigger than 1.4 centimeters, then we plan to put a coil if we are putting an FD. So there was a coil which was put, and this is the FD that was deployed across the, and there was a dissected segment over here where I need to do a balloon angioplasty. So you can see here, there is a flap over here through which the aneurysm has developed. So you can clearly see the flap. See, this is the flap which was there. So we had a follow-up of 6 months. He is completely asymptomatic. Only thing is that he developed dyspnea or breathlessness because of he was on Brilinta, and that's a very known side effect of Brilinta. So we just have reassured that this can happen because of the drug that he's on, and he's doing fine. Now she presented with a SAH predominantly in the left sylvian cistern. So we thought of left MCA aneurysm, and this was the DSA. She had 6 aneurysms. There were 2 aneurysms at the MCA bifurcation. There was aneurysm bigger at the superior division, and at the inferior division, the small aneurysm. And she had a cavernous IC aneurysm as well. Also, she had a small mirror aneurysm on the right MCA. And then she had a dissecting aneurysm of the PCA. There's a big PCA, and there was a dissecting aneurysm in the PCA. And then there was a dissecting aneurysm in the left pica as well. So she had 6 aneurysms. She probably bled into the left MCA aneurysm. We decided to treat her in stepwise. On day 1, we decided that we'll treat the aneurysms on the left MCA and ICA, and then we'll take care of this aneurysm, and we'll treat these 2. The right MCA, which is very small, and this aneurysm probably will require arterial occlusion, and she may develop an infarct, so we thought we will wait for this aneurysm to be treated. So first aneurysm was treated by a balloon-assisted coiling, and then I deployed Elvis Evo into the inferior division, and then we gelled the catheter into that small aneurysm, and we put a small 1 mm coil into this aneurysm, 1.5 mm coil. While coming back, we put an FD into the ICA, and then the anatomy of the vertebral system was very tortuous, and it was very difficult to track the FD into PCA. So Elvis Evo was deployed into the PCA. So she had 3 stents, 2 Elvis Evo, 1 flow diverter, and then these are the coils in these 2 aneurysms, superior division of the MCA and the inferior division of the MCA. She funnily had a very significant prothrombotic state, so she developed a watershed infarcts after putting that. So we again had to take her on table and do an angioplasty of the stent as well as Elvis Evo and the FD, and she recovered completely from these small infarcts that she developed. So this 65-year-old gentleman who had an acute onset headache, vomiting followed by increased sleepiness for 12 hours duration. There was no headache, no loss of consciousness, and he did not have any other risk factors. On examination of irritable neck rigidity present with no focal deficit typical of subarachnoid hemorrhage. And this was the scan who had hydrocephalus with SAH. And this was the aneurysm. He had a basilar top aneurysm, wide neck, around 7.5 mm by 7.5 mm. So either we can do a Y stenting or we can put an intrasaccular device. We decided to put a web. Now, it is a treatment of choice for wide neck bifurcation aneurysms because we don't have to give antiplatelets once we secure the intrasaccular device into the aneurysm. And then we can do EVD or kinetomy post-web, can be done safely if required because this patient has hydrocephalus too. So this was the web which was deployed into the aneurysm sac, and there is a normal filling. All the vessels were preserved. So the disadvantage of web is that one size doesn't fit all. We have to have a precise sizing of the device. Otherwise, it may occlude the arteries which are arising from the bottom of the aneurysm. So we need a 3-dimensional imaging or 2 orthogonal projections when we decide the size of the web. Average width of the aneurysm is taken in 2 different sizes, and then we calculate the average width of the. We take the average as the size of the web. And usually we add 1 millimeter to the width of the aneurysm. So for example, if the aneurysm size is 7, we take a web of 8, and we decide 1 millimeter shorter length of the height of the web. So if say aneurysm is 7 by 3, we take 7 by 4. For example, in this patient, it was 7 by 4. So we chose a web of 8 by 3 because once it becomes compact, its height increases by 1 mm. Again, they have their own via catheters because they are a little stiff distally so that you can retrieve the web. With our routine catheters, you can't retrieve the web into this catheter. So they have this via catheter up to 7. We can use, I think, via 17, and then you require a bigger catheter like 21 and 33 to take bigger web devices. So usually when a patient has cavernous IC aneurysm, we generally don't treat it, we observe. And this lady presented with acute onset of humming sound in her ear, and then in her ear, and then after a day she developed exophthalmos, and she was had difficulty in seeing the object. So by the time she presented to us, she had no vision, and this was a presentation. And so this was a cavernous IC aneurysm possibly which has ruptured and has led to a direct CCF. She had no history of trauma at all. So so I called Dr. Tirochan, and he was kind enough to take my call even in the middle of the night to answer to give me guidance as to how we should treat it. So the plan was to treat there was a very good inferior petrosal sinus that was seen. So you can see that there is a good feeling of the inferior petrosal sinus. So we had a choice to go from the venous side and coil the and close the fistula sac. But the thing is that the artery was ruptured, so it was not a post-traumatic small rent into the artery. Probably the whole aneurysm has ruptured into the cavernous sinus. So I thought that I'll have an arterial and venous access, and then we will use a balloon, and under balloon inflation we will put coils into the sac and we'll fill the fistula. So this was the balloon which was into the wire was into the MCA, and I took an arterial access and a venous access from the inferior petrosal sinus. So this was a catheter from the arterial side, microcatheter for coiling, and we used echelon 10 because it's a Onyx compatible catheter. So if I decide to use Onyx, then I can still put Onyx to this echelon 10 catheter. But when I inflated the balloon, I could see that the artery was much bigger than the balloon, and the balloon also ruptured at the proximal end, and we could not place the coil was coming inside. So we changed the plan. We decided to put a FD into the ICA. So we loaded the patient on table with Brilliant and Ecosprin, and then after 45 minutes we took a stent across the rent. But the issue was the venous catheter wasn't we were not able to negotiate the venous catheter exactly into the sac. This was the first coil which I deployed here, and then I had very limited access from the venous side and the arterial access. So if I put an FD and if the catheter comes out, then probably I'll have to take one more access from maybe by the direct puncture into the orbital vein. So we took a puncture on the left side, left femoral. Again, I took one more microcatheter and I placed it into the sac. So we had two microcatheters from the arterial side, one from the venous side, and then I deployed the stent. So when I deployed the stent, because one microcatheter was along with XT27, as I pulled the XT27, I lost the access of the sac because of this echelon 10. So that also came out of the sac along with XT27. But we still had one more catheter which was gelled, which was gelled very well, and then I started coiling with this. So we put multiple coils. So this was Surpass Evolve. It was 5x40. That's the longest and biggest stent. So around 15 coils we put into this sac, and it was completely gone. So this was pre, and this is post. So we used 420. It was a neuro balloon. We did not use a coronary balloon because I thought it will be difficult to track the balloon. Yes. Single lumen 420 balloon we use. So she did very well. She will be discharged tomorrow. And this patient presented with acute onset of headache and neck pain with 2 episodes of vomiting. Okay, this is a regulation. This is a PCOM aneurysm. And I did a stent-assisted coiling. This is braided stent, which was deployed here. Initially, I started with balloon-assisted coiling, but probably the balloon was not staying here with each beat. It was going up because it was a super compliant balloon that I used. Probably it was a wrong balloon. Then we deployed a stent and gelled the catheter. That's what we do with stent-assisted coiling. We take the microcatheter, we gel it into the aneurysm so that we can put the coils. Little difficult to enter through a braided stent into the aneurysm, so it's better to gel these microcatheters, and then it was coiled completely. Since she was not loaded, we can see that little bit of thrombus formation. She received tirofiban and the thrombus disappeared. She did very well. So this was stent-assisted coiling. This is she presented with SH again, yeah, and there was an aneurysm at the junction of SCA and PCA. So PCA is pretty big, and then this is the aneurysm at the junction of the left PCA and the SCA. So you can see here. So I decided to put a web, a small web of 3 millimeters by 2 millimeters. So initially I used a straight catheter, but then it was going into the PCA, so we changed and we took a pre-shaped 45-degree catheter which went into this aneurysm with a good support from the Sophia catheter, and the web was deployed. You can see here. And it's completely fitting into the aneurysm, and the sky is feeling very well. It's completely spared, and practically we could finish the procedure in 15 minutes. Again, diffuse thick SAH. Patient was relatively well preserved, and this was a big aneurysm. We did balloon-assisted coiling. So there was a small daughter sac which also was taken care by the coils, and this was the scan before discharge, complete disappearance of the blood. Patient did very well. Thank you so much.
Thank you, Dr. Sagar. So any questions? Any questions on this talk? No questions? Okay. Thank you, Dr. Sagar.